is my trauma assessment for acute critical illness 1. We have here an 18-year-old male. He was involved in a motor vehicle accident. Extrication was difficult. EMS report is that he had a GCS of 8, left contusion to his anterior chest, obvious open femur fracture to his left leg with traction in place, and he was found unresponsive. So at this time, I'm going to activate the trauma team. I'm going to go ahead and make sure RT is here with the ventilator. Make sure lab is here. Lab, I'm going to want you to get the following: CBC, CMP, hypercross match, lactic acid, ETOH. Also, nurses, when we were here, get UDS as well. Let's get a magnesium. And RT, I want you to get an ABG as well. We're anticipating using the massive transfusion protocol. It sounded en route he was hemodynamically unstable. So these are our expected findings for this individual. So the individual has arrived at this time. EMS has brought him in. Explained to us the same reported findings. His heart rate is 115, BP 90 over 40, and his stats are in the 80s. Nurse, go ahead and put the vitals on him. Please, let's get him on the monitor. Let me know what his latest vital signs are. Second nurse, I need you to go get him a second IV. They have one that was placed in route. 18 gauge to the right AC. So we're going to start systematically with A, airway. What is my airway? What does he look like? That's my SpO2, nurse.
EKG shows sinus tackling 40s, SpO2 88% on a non-rebreather at 100%. Initial blood pressure 80 over 45, MAP of 40.
Okay, so I'm concerned about circulation before I'm concerned about airway. RT, I need you to go ahead and let's put an OPA in. Nurse, when you put an OPA in correctly here for me, let's go ahead and back him. RT, just get him on a BBM running in 15 liters per minute.
OPA in place.
Oxygenated, keep going. So, what does he look like on the SpO2?
94% from 88 coming out.
Go ahead and remove. Let's go ahead and suction him. Do I have any bloody secretions? Making sure he doesn't have any bloody secretions. Assist the method to take a look at him. Make sure there's no foreign objects, teeth that are not misplaced or dislodged or moving at this point.
Bloody secretions removed, sir.
Excellent. Go ahead and continue bagging. What is my SpO2?
Now he's at 99%, sir.
99%. That's pretty good. Let's go ahead and hyperoxygenate him for the next 2 minutes. With the SpO2 that he's currently on. We're going to hyperoxygenate RT. I want you to go ahead and get me, let's get a MAC food 7.5 based on his body weight, 7.5, and we will do the following ventilator settings. Cut volume of 500. We're going to do FiO2 of 50%, a PEEP of 5, and a rate of 12. Is everything ready for intubation?
2 minute hyperoxygenation completed. He's at 100%. All supplies and suction is set up.
Okay, so C collar is in place. He has a C collar in place. He's been backboarded. So we're going to go ahead and remove the C collar. Nurse, remove the C collar.
C collar is removed. C spring is stabilized.
Okay, C spring is stabilized. Let's go ahead and secrete one more time before we begin.
Secretion's clear.
Okay, so your detector is ready as well. I'm going to go ahead and open the mouth. I'm going to go ahead and correct the pressure in momentarily, not yet. I'm going to go ahead and insert my blade. This is familiar, but I actually prefer the Mac 4. I'm going to use the curved edge to find the vallecula. Move the vallecula on the vallecula. I'm going to lift up. I'm going to look for the vocal cords. I'm going to place my ET2. ET2 5 to 6 centimeters past the vocal cords. And I move here, silent, remove, go ahead and balloon the ET2, please.
Balloon, sir, 10 cc.
Excellent. CO2 positive. CO2 positive. I'm going to go ahead and listen to him at this time. Give it into the goose. I don't hear any breath sounds here. And then epigastric area, left and right, clear lung sounds, apex, bases, clear on the right, diminish on the left is to be expected. Okay, at This time, go ahead and put him on the ventilator with the settings that we discussed, RT.
Ventilator settings in place.
So airway and breathing is okay. What are his vital signs now?
Vital signs remain 90 over 45, map of 50, heart rate 120, 130, sinus.
SpO2?
SpO2 at 100%, sir.
Excellent. Okay, so now at this time, I'm going to go ahead and airway and breathing. I'm going to make sure I get circulation. Full set of vitals have been on there. Do we have our second IV nurse?
Second IV going in, sir.
Second IV going in. Let's go ahead on the right arm AC over here. Let's go ahead and start normal saline.
16 gauge to the
Open,
AC.
16 gauge. Master transfusion protocol. Let's go ahead and do times 1 PRBC, please.
Yes, sir. 1 PRBC going in now.
Excellent. So we have a circulation. Check the sinus. Check central pulses, femoral pulses. I have 3+ here. Carotid. I'll check radial. Excellent. ABC. D disability. Let's get a blood sugar here as well. What is the blood sugar?
Blood sugar of 115, sir.
Okay, so sir, can you hear me? Sir, my name is Ron. This is my Christopher. I'm here to help you. He's not alert. The GCS on arrival was 8. Was unresponsive. Go ahead and put on propofol. Let's maintain him on propofol. At this point now, we're going to go ahead and check his neurological status. The pupils are equal round reactive to light, accommodating 1 milliliter by line, but they are sluggish. Sir, can you squeeze my hands? He is non-responsive to anything. Let's go ahead at this point. So, exposed. We cut him up. We're going to go ahead and put blankets on him, make sure the environment for him is he doesn't become hypothermic. We got another full set of vitals. Where are we at?
Blood pressure now 110 over 65, heart rate 100.
Heart rate 100 in this.
100%, sir.
Excellent. So he's compensating. We've given him the right amount of fluid. Circulation's doing a lot better, and his airway breathing has maintained since we put him on the ventilator. So full set of vitals. Give comfort measures. Let's see if he's in any pain. I'm going to not give him a morphine or anything to the analgesic at this point, but I am going to provide a pillow, put some padding where I need for him. He has a blanket, so we can ensure that he's not in pain. A, B, C, D, E, F, G, H. I'm going to do head-to-toe assessment momentarily. I'm going to get the sample history from the family. Family has arrived. He has no medical history, according to the family, no drug allergies, no surgeries as well. So at this point, I'm going to turn the patient. Let's go ahead and maintain C-spine precautions. Remove it. C-spine precautions, excuse me.
C-collar is removed. C-spine is secure.
Excellent. We're going to turn on your count, nurse.
Ready? 1, 2, 3, turning.
Excellent. Turning off. So at this point, I'm going to check this patient out. I'll start at the cervical, see if there's any step-offs at the cervical. No step-offs. Coming down, looking for any gross deformity up all the way through the back. I'm going to get my loop here. I'm going to check rectal tone. Rectal tone is intact. At this point, remove the backboard, please.
Backboard's out.
Okay, let's go ahead and put the plates in. We're going to check chest, and we're going to check pelvis here as well. Okay, go ahead and lower it back. X-ray, go ahead and shoot for KUB. We're going to do chest X-ray here as well. I anticipate doing CT of the head, CT abdomen, and pelvis. X-ray, what do you see here?
Radiology, clear for X-ray. Shooting, 1, 2, 3, go.
Excellent. Okay, so
There's
I
the
see.
films.
All right, thank you. At this point from the films, he looks like his ET tube is 2 or 3 centimeters above the carina. I did hear breast sounds. It looks like some haziness on the left side, expected with the pulmonary contusion. KUB from this point, I don't see any abnormalities from here. I'm going to go check the patient. As I'm checking the patient here, I'm going to check the pelvis. I'm going to press down immediately, downward immediately. So I do see some the contusion from the left side. I do see some ecchymosis on the left side. I'm going to go ahead and put a pelvic binder. Let's go ahead and put a pelvic binder in this patient.
Pelvic binder is in place, thank you.
I'm going to check for any obvious bleeding, gross bleeding here. There is some bleeding in there. Can you find some pressure on this? He's in a traction split, so we do have obvious femur fracture. Okay, go ahead and bandage that up and wrap it up for me.
Bandage, thank you, sir.
Okay, so at this point, get the trauma team on the phone. I'm gonna inform him that we're gonna get the patient ready for transport.
Trauma's on the line for you, sir, now.
Hey, how you doing, Dr. Flaherty? My name is Ron. I'm the acute care nurse practitioner. Listen, I have here 18-year-old male involved in a motor vehicle accident head-on with a tree. Found unresponsive, not on blood thinners, unknown downtime here. AMS brought him in. We had to intubate him. I had him on AC control, felt like 100, rate of 12. He's setting greater than 95%, FL2 at 50%, ET2 7.5 for this patient, and like 21 at the T. Neurologically, he's a GCS of 3, having a propofol. We shot a chest x-ray, it looks like some pulmonary contusion to the left side, but no hemothorax, no pneumothorax. We're gonna send him in for a CT scan here shortly about for a CT of the head. We gave him times 1 PRDC and times 1 normal saline. He's hemodynamically stable at this time. Um, how do you have me use this patient you were able to receive?
We're willing to accept. No further recommendations. Thank you.
All right, thank you. So at this point, we will transport the patient based on X-ray, CT of the head, CT chest, X-ray, CT of the head, excuse me, CT of abdomen pelvis, X-rays have been performed of the chest, and a KUB. Thank you. So at this time, I'm going to go ahead and begin my FAST exam. Focus assessment with sonography and trauma. So FAST exam is very key for our patients. Because they're unstable for CTs, and we need to see if there's any of the following. So, we're indications for this are blunt trauma or penetrating trauma, which our patient, 18-year-old MBA with epidometry, did suffer from blunt trauma. The answers we're looking for is to see if he has any intraperitoneal free fluid, if he has a pneumothorax, or if he has a hemothorax, as well as a pericardial effusion. If he does have intraperitoneal fluid, we're going to transfuse him with PRBCs. He needs fluid he remains hemodynamically stable. If we find him with a pneumothorax and hemothorax, we're going to apply a chest tube for him. If it's pericardial infusion, we're going to do a pericardial sepsis. There are 4 quadrants we're going to look at. We're going to look at the right quadrant first. We're going to look at the subxiphoid process, the left upper quadrant, and we're going to do the suprapubic region. Also, I'd like to add, the EFAS exam, I'm going to look at the chest, left and right anterior, to see if there's any pneumothorax. There are 10 spaces, and I'll go through each space as I cover each region. As I begin, I'm going to make sure I start horizontally with my probe, make sure I have the probe at the right depth and right gain. I'm going to start horizontally, and then I'm going to turn it oblique. The right upper quadrant, I'm going to be looking at the pleural space. I'm going to be looking at the subphrenic region. I'm going to be looking on the right side, the hepatomegaly, also known as Morrison's pouch, and I'm going to look at the inferior right kidney pole. So in this particular area, as I'm looking in between the ribs, I'm trying to look, and the major thing I'm looking is for the free fluid. So it's going to be a black image is what we're looking at. Any black image indicates fluid. So as I'm looking in the right thorax, seeing if there's any pericardial effusion, see if there's any hemothorax. Pericardial glutter, I'm going to look in the liver tip. Check out the liver tip. Looking at the diaphragm is going to split it in the transverse plane. As I'm pressing in, I'm going to look between the liver above and the kidney below. Morrison sign, hepato. Looking for a mirrored image. Finally, I'm going to go to the flank side, look to the inferior right kidney pole, see if there's any black images around the kidney, and I don't see any at this point. I am going to go the subxiphoid process. I'm going to put it down and inward. I'm going to be looking at the heart around the pericardium, the right ventricular, looking for the crescent shape, looking at the left ventricular, looking at if it's oval shaped. I must add that we have applied plenty of lube for this patient right in the epigastric area before we began. As I'm continuing looking for any kinesis of this patient, make sure there's enough the good squeeze, and there is for this patient. Now we'll go to the left upper quadrant. So horizontally, now turn transverse. Same regions, essentially for here, left upper quadrant, we get the pleural space, subphrenic, splenal, renal, and in left inferior pole. Do not see any black images showing the free fluid. Now I'm going to do the suprapubic area since it's the male. I'm going to be looking at the rectal vesicle of the bladder. If the bladder is black, that means it's full. If it's echogenic, that means it's empty. I'm looking for black fluid around the bladder. For female, I'll be looking at the rectal uterine, also known as the pouch of Douglas. Now I will put my probe perpendicularly. As I put it perpendicularly, I will turn it along the lines of the intercostal space, looking for the sliding of the ribs. Make sure there's no pneumothorax. Change it to MO to see if there's waves in the sandy beach image. And I don't see any pneumothorax. Perpendicular through the intercostal space. And there are no pneumothorax findings. So now at this time, it's time to do the secondary survey. Secondary survey is more focused assessment, making sure I check the patient from head to toe. So I'm going to start with this patient, HENT. So I'm going to look at the head. As I'm checking out the head, we're just going to say make sure it's atraumatic and normal cephalic. I'm going to see if there's any lacerations, obvious deformities. I'm going to be checking on the head, see if there's any bleeding that's continuous. C-spine is still maintained. Eyes, I'm going to go ahead and check the pupils once again. Pupils equal around and reactive to light, accommodating, 1 millimeter dilated, they're still sluggish. I'm going to check the nares to make sure they are patent. They are patent, there is no blood. I want to check the hand here, see if there's any vital signs. Check with an otoscope. Thank you, man. We'll see if there's any hemorrhage. So head, ears, eyes, nose. I want to check the face for any facial crepitus. He does have a left temporal laceration. Bleeding is controlled. Let's go ahead and remove C-collar, please. Maintain C-spine precautions for me. Okay. C-spine precautions. I'm going to check the neck, look and make sure the trachea is midline. There's no lymphadenopathy. I'm going to listen to see if there's any carotid bruits. There's no carotid bruits. I'm going to see if there's any, you can put the C-collar back on, please. See if there's any hematomas. Still no bleeding. No hematomas. I'll look for, feel for crepitus. No subcutaneous emphysema. I already listened to the patient's lung sounds. I already saw this is left contusion to left anterior part of his chest. I'm going to go ahead and feel the central part of his body. If there's any bleeding. Pelvic binders in place. I'm not going to remove that at this time. Check for the abdomen, see if it's soft, non-distended, rounded. For this patient, we did place an OG for him. We did place a Foley for this patient here as well. So he is non-distended. He does have some ecchymosis to the left-hand side. Now I'm going to check the extremities. Cap refill, less than 2 seconds. Radial pulse, 2+, bilat. Very good. Check central pulses. Again. 2+. Now I'm going to check the lower extremities. The right still has a traction splint. Left pulse is 1 plus, right is 2 plus. At this point, I've done my head to toe assessment. I checked head, ears, eyes, nose, and throat. I checked chest. I checked abdomen. I checked pelvis. I checked extremities. I checked vasculature. Foley has been placed. Clear yellow urine. OG is in place. He's ventilated. He is static good at 95%. He is hemodynamically stable, 110 over 64 with a heart rate of 90. We gave him 10-1 PRBC. We gave him normal saline. Has 2 large bore IVs. Once again, DT2 have been placed. Fast exam has been done. Send the patient off for CT. He is stable for CT of the head, CT abdomen pelvis, and patient is ready for transport.